Well, welcome to this episode on medical terminology where I'm going to make sure that we all understand the medical term epistaxis and use it appropriately as healthcare professionals. Yes, this is one of those terms that where the more common word is much easier to use, right? Epistaxis essentially means nosebleed. But as always, guys, the medical term matters because it should trigger a more precise way of thinking. And there is one type of nosebleed that is unique and you don't want to miss it, okay? All right, hey guys, I'm Dr. Busti and welcome to This Is Why, a show dedicated to helping healthcare professionals understand the why behind what we do and what we talk about every day in clinical practice, okay? So today we're talking about epistaxis, not just what the word means, but why nosebleeds happen, who is at greater risk for it, when they may signal something more concerning underlying, and why the location of the bleeding in the nose matters in a very real way, okay? Now, let's start with something that most people recognize from pop culture, right? In movies and TV, a nosebleed usually means something dramatic is happening, right? Think about it. The character is using psychic powers. They're under extreme amounts of stress. Something supernatural and weird is going on, right? Think about that movie Stranger Things, where the character 11, played by Millie Bobby Brown, often develops a nosebleed, right, when she's using her telekinetic powers. It's one of the show's most recognizable visual signals that she is pushing herself, right? Something intense is happening. Well, that idea didn't start with Stranger Things, right? Stephen King's Firestarter, which was published initially as a novel and later adapted to a film, right, also used nosebleeds in association with psychic strain, especially with Andy McGee's mind-controlling ability, right? So in pop culture, guys, the nosebleed becomes this shorthand for some hidden power, hidden pressure, or even danger that's going on, right? But in the real world, clinical practice environment, epistaxis is not a sign of psychic powers, right? It is also not only a diagnosis, but it can be that clue to an underlying problem. And so the real questions that we should be asking ourselves are, why did this patient have a nosebleed? Who is at greater risk? And where in the nose is the bleeding actually coming from, okay? That is the clinical framework for this episode. So let's first define the term. Epistaxis means bleeding from the nose, right? But more formally, we can say epistaxis is bleeding from the nasal cavity, usually from rupture of the blood vessels and that nasal mucosa, okay? The word literally itself from Latin and Greek has a roots, right, connected to the idea of dripping, right? So in a very literal sense, clinically, the word carried out this image of blood literally dripping from the nose. And anybody that's seen it knows that's true, okay? Now, importantly, epistaxis is not also some, random outdated word that only shows up in old medical textbook. It's still actively used in modern clinical medicine, isn't it, right? Even the American Academy of Otolaryngology Head and Neck Surgery Foundation has literally a clinical practice guideline titled Nosebleed, parentheses, epistaxis, okay? The term is also used and can be found very easily in the emergency medicine literature, ENT literature, primary care, and even some patient education. So when a patient says, I have a nosebleed, we may document or discuss it clinically as epistaxis, right? But again, naming it is only step one. The next question is, why does epistaxis happen? Okay, and a good way to organize the causes is this, right? Nosebleeds can happen because something dries, irritates, injures, inflames, structurally disrupts, or prevents the clotting in the nasal mucosa, okay? So that's the big picture. But let's break that down, okay? We're going to go through these individually. So the first and most common category is just basic dryness and mucosal irritation, isn't it? The inside of the nose is lined by that mucosa. And that mucosa has a very rich blood supply because the nose isn't just an air tunnel, right? The nose is there to warm, humidify, filter the air as we breathe it in. And to do that, it needs blood vessels very close to the surface, okay? That is useful physiologically, but it's also makes that lining very vulnerable, doesn't it? Dry air, heated indoor air, winter weather air, high altitudes, or chronic use of nasal oxygen therapy can over-dry that lining. Once that lining gets dry, crusted, it can crack just like chapped skin, okay? And when it cracks over those superficial blood vessels, that's when you get epistaxis, all right? Now, that's category 1. Let's talk about category 2, right? Which is a major one, which is local trauma. That includes facial trauma, nasal injury, maybe nasal instrumentation that sometimes happens in the hospital environment, forceful nose bleeding, blowing, right? And yes, the most common trauma, nose picking. We should not overcomplicate this, right? The anterior nasal septum, especially we'll see in a minute, has a very fragile superficial level of blood vessels that even with minor trauma can rupture them and cause them to bleed. And this is especially common, obviously, for anybody that's got kids or has seen kids who have allergies, colds, dry mucosa, fingers or foreign bodies sometimes go in that nose, right? All right, so that's category 2. All right, category 3 is related to inflammation and infection. All right, think of viral upper respiratory tract infections, sinusitis, allergic rhinitis, non-allergic rhinitis. All of those things can contribute, okay? The inflammation itself makes that mucosa more irritated and vascular, right? There's more flow. But that behavior around it also matters, doesn't it? All right, think about the patient that is sneezing, rubbing, wiping, blowing their nose repeatedly, right? So the blood may not be from the virus or infection itself directly cutting open a vessel, right? It may be from inflamed mucosa plus repeated mechanical irritation, okay? Now the 4th category, and one that we should all keep in the back of our minds, and we probably do see, is medications and substances, okay? Aspirin, other antiplatelet agents that are very well known to impair platelet aggregation and function. Anticoagulants such as warfarin or the DOACs, direct oral anticoagulants, can obviously make bleeding harder to stop once it starts. Think about NSAIDs, very common over the counter, can also contribute, especially through that platelet effect depending on the agent and the context for which it's being used. How about intranasal steroid sprays and the way we administer them? So if you aim it towards the nasal septum, all right, and it's used in that way, that will irritate the mucosa and actually contribute to bleeding. So the technique matters. Intranasal cocaine, right, is a major local irritant and vasoconstrictor that can over time damage the nasal tissue, okay? So one of the useful teaching lines is this: some medications make the vessel more likely to bleed, others make the patient less able to stop bleeding once it starts, right? All right, what about the 5th category, systemic bleeding tendencies, things that we sometimes don't always think about, keep on the top of our mind, but that includes things like thrombocytopenia, platelet dysfunction, right, especially like uremic platelet dysfunction, von Willebrand's disease, hemophilia, underlying liver disease where the coagulopathy starts to occur, obviously patients who have heavy alcohol use who then get liver disease. How about hematologic malignancies such as leukemia, okay? In those cases, the nose may be where the bleeding shows up, but listen guys, it's the identifier to an underlying systemic problem that could be missed if you just anchor on the nosebleed. So a tiny mucosal injury that would normally stop quickly may be prolonged, recurrent, and more dramatic because the patient's clotting system is impaired for some reason. And finally, we have the structural or vascular causes, right? Think about a deviated septum, nasal septal perforation, nasal polyps, nasal tumors, vascular malformations. How about hereditary hemorrhagic telangiectasia, also known as HHT? All of those can be relevant, right? And the clinical warning here is that recurrent, unilateral, severe, unexplained, or unusual bleeding that should automatically be blamed by only dry, irritated, or even nose picking, right? All right, now let's separate some of those classic causes from the risk factors, right? A cause is what starts the bleed, but we've already discussed patients that have causes and align with those risk factors, so it makes sense. But there's one I want to touch on a little bit further, and that is hypertension. High blood pressure is often blamed for nosebleeds, but it's probably better to teach it this way, right? Hypertension may make the nosebleed more persistent and more difficult to control, but we should be careful about saying it is the sole or absolute cause for the most nosebleeds, okay? We still need to look for that local trigger, the medication effect, or underlying bleeding risk. So hypertension may certainly contribute to the persistence of bleeding that has already started, but it should not automatically stop your thinking, okay? All right, so now that we know why patients bleed, who is at risk, we can finally ask, where is the bleeding actually coming from, okay? This is where the anatomy and physiology becomes very practical and clinically relevant, okay? So follow me here. The nasal cavity has a blood supply from both, listen, the internal and external carotid arteries, okay? The major vessels we commonly emphasize coming off of those include the anterior ethmoid artery, the posterior ethmoid artery, okay? That's one of the things that differentiates them from anterior versus posterior nosebleeds, sphenopalatine artery, and then the greater palatine artery and superior labial artery, right? Now those branches contribute to vascular networks in that nasal cavity, especially along the nasal septum. The most famous is Kiesselbach's plexus, okay? It's also known as Little's area. It's in the anterior portion of the nasal septum, okay? This is where the anterior posterior vascular meeting point and where those vessels are most superficial, okay, and close to the surface. That is why, okay, many anterior nosebleeds come from this region. So we divide epistaxis, remember, into two broad categories, anterior and posterior. And anterior epistaxis is more common. It's usually coming from that front part of the nasal septum, often in that Kiesselbach's plexus near the surface. The blood supply usually comes out forward from the nostril, right, in a dripping manner. And the source may be easier for you to visually see. Treatment is often also more straightforward. It's the posterior epistaxis that is less common, but usually more clinically concerning. It comes from deeper in that nasal cavity, may involve those larger vessels literally coming from more of an arterial supply, and it may drain backward into the throat. It's obviously also a little bit harder to visualize since it's not dripping out of the front. That means it's also harder to control. Now, posterior bleeds are more common in older patients and may require more aggressive management and even involved our colleagues, otolaryngologists or ENTs, to be involved, okay? And this is why the location matters. If the bleed is anterior, we can often compress it. We can access it, visualize it, apply topical vasoconstrictors, cauterize a visible bleeding site, or even pack it with anterior packing. If the bleed is posterior, the source may be deeper, larger, and less accessible. And that may require posterior packing, nasal endoscopy, ENT consultation, as I just mentioned, arterial ligation, and even potentially interventional radiology to embolize selected cases. Now, that is not a procedural lecture, right? But let's summarize the basic treatment concept here, right? First, assess severity. Is the patient stable? Are they protecting their airway? Is the bleeding heavy? Okay. Are they on anticoagulants or antiplatelets? Do they have anemia, bleeding disorders, or other risk factors that you need to consider? So for a typical nosebleed, all right, the basic first step is to sit upright, let gravity help you, lean forward, right, and then apply firm, sustained pressure to that lower part of the nose, okay, not the obviously hard, bony bridge, okay. Leaning forward matters because it also prevents that blood from running down the back of the throat, okay. If bleeding does continue, they can use topical vasoconstrictors, remove clots to visualize the source, cauterize that visible anterior bleeding site, or even institute nasal packing. If the bleeding is severe, posterior, recurrent, or difficult to control, some sort of associated disease, that's when our escalation needs to become more important and initiated. So here's the takeaway, guys. Epistaxis means nosebleed. It's a simple word, common problem, right? But clinically, it should trigger a disciplined thought process by you. Why did that vessel bleed? Okay, is this a local issue like dryness, trauma, inflammation, or nasal irritation? Or is this a medication issue like anticoagulants, antiplatelet drugs, NSAIDs, intranasal steroid drug exposure being used wrong, right? Is this a part of a systemic disease or a structural lesion? And finally, where is that blood coming from? Anterior versus posterior. All right, because once you understand that anatomy, the treatment plan really actually starts to make sense. That's the how we talk about. So anterior bleeds are often usually accessible and often easier to control. Posterior bleeds are deeper, harder to visualize, more likely to need that escalation, all right? So Hollywood may use nosebleeds to show a psychic level of strain or something concerning, but clinicians use epistaxis as a vascular clue, and that is why the term matters. I hope that this episode was helpful, interesting, but also clinically relevant in bringing back some of the old things of even anatomy and physiology, okay? If it was, please consider subscribing to the channel. Share this with your colleagues, students, residents, anyone that's interested in just learning the language of medicine, right? I'm Dr. Busti, and remember, never stop learning the why, because that is what helps us to master the how we take care of patients and maximize the benefits of our care and improve outcomes. Take care.